You've only got one machine, one probe, and one shot. If you are the only one who knows how to use ultrasound, then you are the expert.
You are listening to Sound Waves from the Community with your host, Dr. Tyler DeShawn.
Hello, and welcome to another episode of Sound Waves from the Community podcast. I'm your host, Dr. Tyler DeShawn. Now, in today's episode, we're going to be discussing a topic that has been requested to me from multiple sources, mostly the nurses that I work with and our advanced practice providers, but I know that there are a lot of physicians that this can serve as well. And we're going to be discussing ultrasound-guided peripheral IVs. And this isn't necessarily a glamorous topic, but can be extremely helpful for both you and your patients so that you can get your labs done and the patients can get their vascular access, their meds, and be able to get what they need done with minimal amounts of poking and needle stick attempts. So if you're like me, I'm sure you've had a patient, at least several, where they came in and for whatever reason, either they're a cancer patient, they might be a renal patient on dialysis, IV drug user, frequent flyer of the ED from gastroparesis, or whatever it is, and they just have really difficult vascular access. And so the nurse tries several times. They get like the crisis team. They might get lab to come down and try and draw. Eventually might have to call like a PIC team or ask someone who can use ultrasound to be able to get an ultrasound-guided IV. And I know I've had times where I've actually been requested to put in a central line, and I asked why the patient needed a central line because, their blood pressure was fine. There weren't any critical medicines that they needed to receive, multiple medications at the same time that would actually require a central line. But they couldn't get access. And so rather than, putting in an IO or something like that, they just wanted to have some sort of access, and central line was the only thing they could think of. And so instead I went in and put in, two ultrasound-guided peripheral IVs, large bores. And it's almost like cheating, being able to see the vein and the needle at the same time and just guide your needle to that target. But this is an extremely helpful procedure to be able to do for, again, both you and your patient, as well as for your nurses. I know it can be super frustrating for them to not be able to get vascular access. And so following the I-AIM technique that we've discussed before, indication, acquisition, interpretation, and management, the indication is a patient needs vascular access. They need an IV for whatever reason. And it may be someone who has had, multiple attempts or is a difficult stick, or it could be someone, if you're practicing, I would say if you've got someone who's got, very visible or palpable veins, use ultrasound then, because it's going to give you the confidence and the skills to perform the procedure, with minimal risk or, the minimal, what would you say? Give you the greatest likelihood of success, especially for your first 10 attempts or so. I'd pick the easiest, biggest veins that you can find and use ultrasound and go that route. Because if you start doing ultrasound with minimal experience and are trying this on the patients that nobody can get, there's a high likelihood that you're going to fail. And so your indication, someone needs an IV. Acquisition, so you're going to use the linear probe. You want a high frequency probe. It's going to give you the most shallow depth. You probably don't want to be going more than 2 or 3 centimeters unless you have a really long peripheral catheter. If you don't, then, something like inline. If you've got, especially if you've only have like regular IVs that are like 1 1/4 inch or 3/4 of an inch long, if you go any deeper than like 1.5 inches, or a centimeter and a half, there's no way that you're going to have enough catheter to get down to that vein. Because again, you're not going perfectly perpendicular to the patient's arm. You're going in at least at, a 45 degree angle or lower to try and get that vein. So you actually have a longer distance that you've got to cover. So you want as long a catheter as possible that you can get. And you want to keep your field of view, the maximum depth between 2 and 3 centimeters. I would lean towards 2, especially starting out. If you can't find something more shallow than 2 centimeters, you need to look somewhere else. And so you got the linear high frequency probe, adjust your depth. There should be settings on the machine where you can set it for peripheral vascular access. So it's not set to, like ocular or MSK or something else like that. It just gives you the best chance of getting a good picture, following your needle down to the vein. And to acquire the image, what you're going to do is you want to go, I usually go right around the antecubital fossa, and, look for the veins that you would typically go for anyways, and just kind of slide side to side until you find some anechoic circular structures. So you're going to be doing a short axis view, and I would recommend doing a short axis or an out of plane approach for most of these, just because the veins are so small and tortuous. It's difficult to do an in plane or long axis approach with ultrasound guided vascular access. And so look in the ancubital fossa, you're going to find an anechoic circle. It should have hypo or hyperechoic walls, and it should be very easily compressible. Now, the caveat to this is, especially if the patient's got borderline blood pressure, if you push down very forcefully with the probe, you're going to get the arteries to collapse. So you'll see if you just sit there and kind of hammer up and down repeatedly, you're going to see that artery, do a little bit of collapse and call it a vein and end up with an arterial stick, which isn't what you're going for most of the time, especially with a peripheral IV. So what you want to do is you want to slowly put down pressure gradually, and what you'll see is you'll start to see the veins collapse, and they should very easily completely collapse, especially when you're out, in the distal extremities. It shouldn't take much pressure at all to get those collapsed. In fact, if you put much more pressure than just gently resting the probe on the patient's skin, you're going to get a lot of the superficial veins to collapse. So I would suggest applying very, very minimal pressure with a generous amount of gel, and that will allow you to use the gel as your interface without applying hardly any pressure to see those small veins that you might otherwise miss. But when you're putting pressure down to confirm artery versus vein, put pressure down slowly and then hold it. When you get the vessel halfway collapsed, just look at it. If it's pulsating, it's not a vein, it's an artery. But if you just hammer up and down, there's no way you're going to see the pulsations. You're not going to be able to see if it's an artery or vein. So I'd recommend going slowly, get it halfway collapsed, and look if it pulses. And a lot of times you're going to see the veins right next to an artery. So if you see a cluster of anechoic structures, the ones that collapse first are going to be the veins. So again, slide side to side. I would sweep up and down the arm as well to see if it dives, if it splits, if it gets bigger. You want to know which direction this vein is going. So once you start your attempt, you know which angle to direction your needle so that you can get the needle tip into that vein. And so that's going to be your acquisition. I guess the other part of this is just the procedure itself. Obviously you're going to want a tourniquet unless you're going for, if you're using ultrasound-guided IJs, obviously you don't want a tourniquet around the patient's neck. But anywhere else you're going to want a tourniquet to try and get those veins as big as possible. And what I like to do, especially on the arms, is I like to get a towel and roll up the towel and put it underneath the arm. So instead of having their elbow kind of crooked down and bent like this, you can get it nice and straight, so that you've got a nice straight trajectory. Because if you're going at a fairly steep angle, or even more so if you're going shallow and that's bent, you're going to have a hard time getting the angle that you need to get into your access. And you want to use sterile gel for this. So if you just get the sterile Surgilube packets that you use for rectal exams, those packets are sterile. The gel's sterile out of the packet, and so you can use that. You don't have to have the expensive or more expensive kits with the sterile probe cover and the sterile gel that comes in that. You can just use the sterile Surgilube packets. I would put something over the end of the probe though, and there's been a debate about this. There have been research articles that have been done, and I don't know that there's a consensus per se, but you do want to put something over the probe, and it's not to keep a sterile probe cover to protect the patient, because when nurses do this, they've got just regular gloves on. It's not a sterile procedure, right? It's a clean procedure. But you don't want to get blood on the probes, because the probes do not typically undergo a complete sterilization process. You just do, a standard cleaning process and put the probe back. And so you want to keep blood off of the probe so that you don't potentially contaminate the next patient that's exposed to the probe. And so I'm personally fine using Tegaderm, just a regular exam glove. You can use a sterile probe cover. Whatever you decide to put on there, but put something on there. Something is better than nothing. And there can be a debate about if a Tegaderm is good enough or not, but it puts something on there. But you've got to know that you always have to have gel in contact with the probe surface, with the scanning end of the probe. So you've got to put gel on the probe, put on your probe cover, and then put gel on the patient as well. There's kind of like a gel sandwich there. So you got to have gel on both sides, on the probe and on the patient side. Otherwise, you're not going to be able to see anything. You're going to get air artifact. And so, get a cover on the probe. You can clean the end of the probe off after you get your cover on there. You want to clean the skin, use a sterile gel. That's going to be the safest way to do this. And again, get the longest catheter you can get. If you can get like a 1 3/4 inch or a 2 1/4 inch, 2.5 inch IV catheter, it just makes it so much better. So once you you get that needle in there, you can really thread that catheter and it doesn't pull out as soon as the patient's redundant tissue moves out of the way. And so once you've got your image acquired, you've got everything set up, there's a 3-step process that I follow that I think can help you be very successful. Even if you feel comfortable with putting in peripheral IVs, I think following these will help you be even more successful and have less pokes and less likely failure rate with these. And so what I do is first get the North Star sign. So 1, get your North Star. 2, leapfrog. 3, drop and advance. So 1, North Star. So this is a coin that was turned at Ohio State, and I don't know who specifically. It might have been Dr. David Boehner. Someone else may have come up with it, but it was what we were taught when we were at OSU. And what that is before you actually use the needle to penetrate skin, you want to get the probe on the patient, and you want to get the image centered, and there should be some sort of center marking on the probe, a triangle, little teardrop shape, something that points to the center of your probe. And then what you're going to do is you're going to rest your needle right on top of the patient's skin, flat. You're not penetrating the skin. You're just resting it flat. This should not be painful at all. You lift up your probe and you put it down on top of the needle. And what you're going to see is, if you look at the images that we've got, you'll see a hyperechoic dot on the very, very near surface, the near field of the ultrasound image. You're going to see a hyperechoic dot from the needle, and then you're going to see a ring down artifact coming down from the needle tip down through the deeper portions of your image. And so what that allows you to do is center your needle before you poke the patient. And with these small veins especially, it is critical. If you're off a couple of millimeters, you may not be able to get the angle you need to get to that vein successfully. So before you even poke, get that needle centered. How do you center the needle over the vein? By getting the North Star sign. If you're not centered, what you do then is you just lift up your probe, adjust your needle to the left or the right, and then put the probe back down. And I guess the caveat I should have mentioned earlier is you want the leading edge always to your left. No matter where you're at in relationship to the patient, put the leading edge to your left so that when you adjust your needle left or right, it's going to go left and right on the screen. The leading edge of the screen should be on the left with the indicator on the left of the screen. The leading edge of the probe should be pointing to your left, not the patient's left or the patient's right, always to your left. And now, once you've got your needle centered, then what you're going to do is start what's called step 2 is the leapfrog technique. North Star, step 1, step 2, leapfrog. What you want to do is, if you imagine sound waves coming out of the ultrasound probe as a plane, a really thin sheet of paper plane, the only way to know where the dangerous part of your needle is, the needle tip, is to keep that tip in the plane. Because if you imagine that plane's coming down through the patient's arm, if you penetrate that needle out the back end of that plane, you've lost your needle tip and you don't have any idea what you're poking anymore. You could be poking, deeper into the muscle. It could be hitting bone. You could be hitting an artery that's adjacent to the vein. You have no idea where that is. You have to keep track of your needle tip. The way you do that is, as soon as the needle tip hits that plane, you sweep the probe away from you, approximately up the patient's arm, and you sweep the probe away just a couple of millimeters, just a small sweep away. And what's going to happen is you're going to see that hyperechoic dot disappear off the screen. So you want to see the hyperechoic dot, see the needle tip, stop moving the needle, move the probe away from you. Once you don't see the needle anymore, slowly advance your needle until you see that hyperechoic dot, that tip of the needle, come back into the sound wave plane. When you see the dot, stop the needle, move the probe. Move the needle, move the probe. And you sit there and leapfrog back and forth until the needle tip is right over the anterior surface or the superficial surface of the vein. And then what I like to do is give it a little jab, because there's going to be some tissue built up on the end of the needle. And if you get a little jab, it kind of pushes through that tissue and can puncture the anterior wall of the vein. And then at that point, you should get a flash. If you want to look down, you can. There should be a nurse or someone else helping you. I would recommend, so that way once you get the IV in, they can get all the tubes and everything that they need and get the IV started. But you can ask them, is there a flash? If there's not, and it looks like the tip is in the vein, what's probably happened is that tissue is built up and it's still stacked on the tip of the needle. So what you've done is, instead of penetrating through the wall, you've kind of invaginated it or pushed the wall in to the lumen of the vessel. So it looks like the needle's in, but it hasn't actually gone through the tissue. And what you need to do is just give it a little jab, and then it'll go through, and then you'll be inside the vein. So that's step 2, leapfrog until you're in the vein. But I would not stop there. I do not advance at that point, because what can happen is, if you've gone a decent depth, all of the resistance is around the catheter. There's really no resistance once you get past the needle tip into the vein. There's no resistance on the needle anymore. It's all on that catheter. If you barely get that bevel into the vein, but the catheter's still outside the vessel wall, when you advance that catheter, what can happen is instead of advancing through the tissue into the vein, it just pushes. With that resistance, it just pushes all the tissue down. You pull your needle out, and the catheter never makes it in, and now you have no flash. The IV doesn't work, and you have to do it all over again because you didn't get that IV into the vessel. So step 3 is drop your angle and advance. Drop and advance. So if you're coming in at 45-degree angle, you've penetrated that vessel wall, you should see that bright white dot somewhere inside the lumen of the vessel in that anechoic circular space. What I like to do is leapfrog it just a couple more millimeters until that tip is close to the posterior wall, and then I'll drop my angle and flatten it down. And what that does is it lifts the needle tip up towards the anterior wall of the vessel. So again, I'm not advancing it in anymore. I'm just dropping the angle until it's by the anterior wall, and then I'll leapfrog it a couple of more times. And that will keep you from getting only the bevel of the needle in and not the catheter. You'll actually advance some of that catheter into the vein. And once that catheter is in there, even if the needle came out, you've got at least a little bit of catheter in the vein, and you should be able to get it advanced the rest of the way. So step 1, center your needle over your target with the North Star sign. Step 2, you want to leapfrog. Keep that sound wave plane just in front of the needle tip. So as soon as you hit the needle into the plane, you move the probe away from you, leapfrog until you get into the vessel. Once you're in the vessel, drop and advance. And that's how you're going to be able to be most successful with IVs. And I would recommend practicing this. You can use tofu blocks. I use ballistics gel phantom models that gives you a pretty good simulation of tissue. You can use it multiple times. When the ballistics gel is all shredded and scarred down, you can just melt it and remold it. And I'll have a link in the show notes and in the video summary that if you want to purchase a kit, I do sell them. You can make them on your own. You can, Google how to make, ballistics gel vascular phantoms, and there are websites that sell this. If you want to buy a higher end model, Blue Phantom is a really popular brand. There are other brands out there as well, but it just gives you the practice of where you can simulate this, without potentially causing some pain and missing, a needle placement on a patient. But again, when you are practicing with patients, I would start with the easy ones, because if you start with the hard patients, it's just going to make it harder on you. You're going to be unsuccessful and get frustrated, and the patient can get frustrated as well. So get lots of practice in. This is all about hands-eye coordination. The more you do, the easier it gets. I've probably done hundreds or thousands of these, and I very, very, very rarely don't get these anymore, even on the toughest patients, because I've practiced. I've been able to find where these, where the good veins are. And, once you get this down, you can just about throw whatever gauge where it's just slightly smaller than the lumen size of the vessel, and you can get it into these tiny little tortuous vessels. So get out there, get your hands on needles, practice with the probe, and really get this down, because this can really help your patients, especially when you've got a critical patient that needs access, that may not need a central line, and the potential complications with that. They just need a blood draw. They need to get things going. This can help you, your patients, and your nurses. And if you are a nurse watching this, this can really help speed things up for the physicians, and they will really appreciate you having this skill to be able to help better serve your patients. Again, watch this video again, get lots of practice in. This is all about practice. There is no way to get good at this without practicing. And if you've done, several dozens of these, hundreds of these, you can really get efficient. And I've had patients say they don't even feel it, that they felt no pain. They didn't feel the needle. It's not often, but I've had multiple patients tell me that, and that they really appreciated that, someone had this skill to use ultrasound to put in an IV, because they always have a bad experience whenever anyone tries to get a blood draw on them. So I hope hopefully this is helpful for you. I apologize about the lapse in the videos. There's been a lot going on, but I'm going to try and get these out more regularly. And again, every shift, get out and do a scan. Whether it's peripheral IVs, a procedure, something that's just practice. The patient doesn't actually need an exam, but get out there and practice, because the more you do, the better you're going to get. Take care. We are committed to serving you, our community ultrasound brothers and sisters. If you find this podcast to be of great value, please subscribe on Apple Podcast, Google Play, or Stitcher, and please leave us a review. If you have a specific request or feedback, feel free to email us at communitysoundwaves@gmail.com. You can follow us on Twitter at Megasound, Megusound. Stay healthy and be safe.